yet another edition of our Spotlight series, Season 2, which is a series of webinars on sexual and reproductive health and rights. The Spotlight series is attempts to bring to all of you various nuanced conversations around sexual and reproductive health and rights in this season. So let us start today. I'm going to take a moment to introduce each of the speakers to you. Dr. Kalpana Apte, the Director General of FPAI. Next, of course, another well-known face for this forum is Dr. Ratnamala Desai, who is our President of the Family Planning Association of India. Last but not the least, we have the key expert for today's discussion, that is Dr. Parikshit Tank, the three experts today. And the format of the session is such that Dr. Tank will be taking us through the technicalities, how to evaluate the male partner, what to expect, how to diagnose, what are the treatment options. And after the technical session, after his talk, he is going to join the panel, which is going to be a little more broad-based, a discussion about something that we deal with on a day-to-day basis.
When we say there's a male factor in the fertility issue, what exactly are we talking about? It's, what is obvious would be that the semen analysis of this particular man is abnormal. Either there is oligospermia, that means the sperm count is very low. There is asthenozoospermia, that means there are sperms, but they hardly move. There is no motility or very poor motility. There could be teratozoospermia. That means there are sperms, they move, but they are all abnormal. The structural features don't indicate normality. Or there could be a combination of these, which is actually probably the most common thing which we see on semen reports. So we just call it OATZ, that is oligoasthenoteratozoospermia. So that's the most common type of abnormality that one gets on a semen analysis. The extreme form of this situation is azoospermia. That means no sperm in the report at all. But there can be so much which can be wrong with the entire situation. And this includes male sexual dysfunction, which could be functional, which is way more common than organic pathology. Organic pathology means erectile dysfunction or ejaculatory dysfunction, which is because of, say, diabetes mellitus, for example, or the man is on certain medications. He has a spinal cord problem. He has an injury to the scrotum or the genital tract. So sorry, excuse me. So these are all organic. But more often than not, what we come across is a functional problem. So all these broad sexual dysfunctions also contribute to the male factor. And of course, there is a lack of education or knowledge. Sometimes there's a lack of interest because people are working double shifts or they are so absorbed in other things. And the frequency of intercourse being very low, lack of frequency. So all these things broadly would comprise the male factor. Why should you bother about the male? Because this is the problem in 50% of couples who are not able to get pregnant. So if you're not addressing this population, you're serving only half the people. At least if we can't do anything else, we can at least provide counseling. What are our goals of evaluation? We want to know what is the male fertility potential. And if it is subfertile, then can we correct it by some means? A very important question is, if a couple is coming to you for a fertility problem, can you really identify that there is a male factor just by clinical evaluation? The semen cannot be judged on clinical grounds. So a semen analysis is a mandatory part of evaluating a couple. Do not delay it. Don't do it after you have done so many investigations for the woman and after doing invasive procedures. No, that's not the time to do it. It's probably the first thing that we should do when a couple is being assessed or evaluated. Personal habits are also contributory to certain extent. Smoking, consuming tobacco in other forms, excessive alcohol intake, heat exposure, mainly by profession, and one very big growing problem, and that's obesity. These are the four things that we are currently looking at when we say unexplained male factor. What are we looking at? We are looking at age because a number of older men are wanting to become fathers. We are looking at difficult lifestyles in terms of obesity, alcohol, tobacco, not the right type of food, drugs, anxiety, stress. We are looking at pathophysiology of various diseases and the environment, which all go on to make their contributions to the male factor. Now, some ground rules for interpreting a semen analysis. If you have a normal report, take it as normal. But if you have one abnormal report, it's not always abnormal. Always repeat a semen analysis after a few weeks to make sure that it was not one of fluctuation. I strongly believe that couples who have a fertility issue in general and who will need anything more than the most basic kind of counseling and treatment should be talked to about and offered treatment with donor sperm in terms of an IUI or adoption as appropriate to that particular clinical setting. So even though we have great technological advances, we have to keep in mind the social fabric, what is the financial capacity of that particular couple, offer them different choices, and then let them arrive at some kind of a decision which you can help. A healthy life, including a balanced diet, exercise, and reducing stress. But really speaking, the largest problem that we face today, especially in urban clinical practice, is obesity. People talk about micronutrients and vitamins and this and that and the other, but macronutrients are much more important. And the obesity is going to affect male factor in at so many levels, including the ability to simply have intercourse, the type of spermatogenesis which is there, lipido, the level of stress, so on and so forth.
The question is excessive masturbation one cause for erectile dysfunction?
Uh, well, anything that's overdone. Yes, I would agree in that sense that excessive masturbation, please, I'm going to ask you to underline excessive over there, could be a reason for erectile dysfunction because, the mind and the muscle both get exhausted and, the simple pleasures may get blunted when it is excessive. I mean, I don't mean to by any means suggest that
Oligospermia and azoospermia are the hurdles to proceed further and how to treat such cases.
we did touch upon the initial, thought process that should go into the management of somebody who comes with an oligospermia. Well, frankly, if it's an azoospermia, there's really nothing much that one can do at the initial point of contact or a primary level service. So those should very fairly be directed to a fertility clinic or an expert. If it's a borderline report, if it's something which seems to be just a little bit of a deviation from the norm, it would be worth exploring at the first instance if there are any correctable factors. Some which I did mention would be diabetes, obesity, hypothyroidism, lifestyle issues which can be addressed. Depending on what facilities one has at a particular unit, one might consider intervention like an intrauterine insemination if there is a facility to prepare sperm for that, or the couple might need assisted reproduction. That's the next option here.
You have nothing more to do except counseling. And many a time, counseling does help. Counseling helps, lifestyle modification helps, and of course, some antioxidants. And I think you can do a lot of good work by talking to them, counseling them, and some point of time we have to refer them.
Do you think age of the male partner has any bearing on these findings? Health of the ovulation is changing with the aging. So what aging has to do with the sperm quality and quantity? Okay.
So the changes that we see for a woman, which kind of accelerate between the age of 35 to 40, those seem to happen to men between 45 to 50.
50.
That's just biology. But women have a shorter reproductive lifespan, whereas men tend to have a much longer reproductive lifespan. But yes, age is important for the man too.
What could be some of 2 or 3 important aspects that we must tell them about? Psychosocial counseling.
I think, one very important aspect of taking a history of a couple who comes to you is to address whether they are having intercourse or not in terms of talking about sexuality. Even though the problem is technically infertility, it may actually be directed towards sexuality. So provide an opening for the couple to talk about it. I think if we just do that, you'll be surprised to hear stories of both male as well as female sexual dysfunction. And sometimes it's just rumor or myth or some piece of misinformation that they've heard and anchored their whole sexual lives around. And if you can just address that and get rid of it, you might solve a big problem.
Taking history together and separately is important. So counseling, depending on the individual problem, we'll have to counsel depending upon their social issues.
Mostly women, even today, report for infertility. So what's the percent of couples coming together as against the woman coming alone? And what's the percent, or you can say the trend nowadays, of men accompanying women and accepting that they are the 50% of the fertility equation?
So I think, it's a lot to do with geography. I mean, where are you in India? If you're sitting, in a posh clinic in a metro city, you'll see a fairly large proportion of couples who will come, men and women who will come for a consultation for a fertility issue. If you're sitting in, say, a medical college in the same city, or some of the less economically served areas, you're going to see a picture which is similar to what you would see in a rural background or a small town, where typically the woman will come either with her mother, mother-in-law, friend, sister. I mean, how involved are men? That varies. I mean, varies by class, by socioeconomic status, the cultural background.
We are still a patriarchal society.
Hmm.
Still, it is the woman who is to take the blame all the time. And majority of the time is the woman with the mother or the mother-in-law. And we have to invite the husband to come for investigations. Things are changing. As you said, things are changing. And these days they do come forward.
What about the donor's sperm, even for ART or otherwise? What would be the legal and ethical issues around that in India today?
So, when it comes to the legal aspects, there are certain criteria which have been put forth in the ART Act. That includes what the age of a sperm donor should be, the kind of tests that they would have to undergo, etc., etc. All that is pretty straightforward. Then there are certain conditions. That means a sperm donor can donate only once in his lifetime.
Oh, really?
Yes, and a particular couple should try and use the sperm of a particular individual sperm donor. So let's say a couple who wants to have a intrauterine insemination with donor sperm, then that man may donate to the same semen bank multiple times, but it should be used for only that one couple.
Oh, okay.
So this is something new, and this is something which wasn't there before the ART law came in 2021.
If there is a sexual intercourse and the ovum is ready, she is going to become pregnant. She has nothing to do with sexuality, sexual desire, or there is sexual health plays a very minor role. But for a male, that is the beginning of his fertility. Unless he is aroused, unless there is an erection and ejaculation. And that's why for male infertility, we cannot forget the bigger role also of sexual health. And FPI clinics have that an ample capacity to provide that kind of information and counseling to men who come to us for proper consummation, proper sexual intercourse, and anxiety about premature ejaculation, and so many things that we normally use for contraception. On the other way around, it can be also used for fertility advice to men and boys. What is the government's investment in addressing male infertility?
Nothing much.
Nothing much, even female infertility for that matter.
No,
I don't think.
I think it's not really fashionable to have governments say that they're going to help to increase the population. It's a very counterintuitive kind of a thing what governments can do. But recently, some public hospitals have started fertility clinics, fertility units in Mumbai. But these are far and few. You come across one or two which get established, don't run very well. So in the public health space, as Dr. Apte did mention earlier, there's hardly anything what can be done in terms of fertility enhancement.
Well, as infertility is an individual problem. So the government doesn't focus on infertility per se, but when we are talking of reproductive health, it includes both, so that the couple can plan the number of children as and when they want. So, but as I know, the government is also reimbursing infertility expenses to the tune of 60,000 rupees.
Rather than this. So we have a lot of work to do at the policy level, at the clinical level, at the psychosocial and sexual health level, and also not understood clearly because we focus only on women, and fertility is seen to be women's domain, not really understood to be an important 50% equation of men in the ratio of infertility or fertility for that matter.
Part of the job is counseling. So even at our FPAI level, though we are not going to do IUI or anything of that sort, we can do preliminary investigation, a proper history, a proper examination, basic investigations, and counseling. That will go a long way, and many of them will conceive in the course of counseling.
Thank you so much. But all of you covered all the aspects, the public health aspect, the social aspect, and of course the technical aspects. Thank you so much, everyone.